as your moderator while our designated moderator is joining us shortly. We have had 2 virtual sessions planned for today. One was focusing on the Eastern time zones, which we already had held, and it is live on YouTube, on the YouTube channel of Neglected Tropical Disease Department of WHO. And with this we are starting the what we call the ISBAD West, which is the focusing on the WHO Afro and Americas. So in these sessions, we are going to share the progress and the challenges encountered while translating the set out goals of the global strategy, and how from visions to actions work, and how WHO is implementing its global snakebite strategy. And at the end of this session, which would have 2 presentations from WHO headquarters as well as WHO Afro and WHO PAHO, we will have a panel discussion. So we would encourage audience to share their questions while the presentations are ongoing using the Q&A of the Zoom link or else the chat of YouTube. With that, I would give the floor to Dr. David Williams, who is the WHO's Regulation and Pre-Qualification Department member, who is leading and coordinating the implementation of the global strategy of snakebite and venoming. David, the floor is yours.
Okay. Let's see where we are. I won't be a moment, Kelsey. I'll just find the right presentation to put up.
Sounds good. And we have Mike joined us. So
and right, good morning, or good evening, I guess it is. No, good morning for everyone in Sub-Saharan Africa, Europe and the Americas. So my name's David Williams. I work with WHO's Pre-Qualification Department, as well as with our colleagues in NTD, working towards the implementation of WHO's snakebite strategy. Hopefully in a moment we will see this screen full-sized. There we go. So what I want to do today is give you just a brief update on the 4 key pillars of the roadmap, which of course are engaging, empowering communities, strengthening health systems, partnerships and coordination, and ensuring safe and effective treatments. And if we start with communities, because that's really where the first steps in solving the snakebite problem lie, WHO has been working towards the publication of a community engagement toolkit based on extensive consultation with stakeholders from right around the world to help them to better operationalise, to coordinate their messaging, to give them access to tools that can make the work that they do much more effective, particularly in terms of monitoring, reporting and evaluation of the success of the work that they do. And of course, we also support International Snakebite Awareness Day with these webinars that we have every year and with other activities throughout the year. As well as communities, it's very important that we have good, strong, robust health systems. And so over the last year, we've been working on the development of a set of minimum health facility requirements for health facilities at different levels to be able to effectively manage and treat snake bites. That work is beginning in Sub-Saharan Africa and eventually it'll extend to other regions. In hand with that, we're also working around the development of a couple of procurement packs which would be available to countries through WHO's procurement team. One would be a set of minimum commodities for anti-venom administration. In other words, all the other things that you need apart from the actual vials of the anti-venom itself to be able to administer it and administer it safely and deal with early adverse reactions. And in addition to that, a wound care package, among other things, for dealing with the consequences of cytotoxic, myotoxic or necrotic snake bites. And we also support countries through the epidemiological data collection via the District Health Improvement Information System 2, DHIS2. And that's a tool that enables us to get a bit of a benchmark as to what data countries currently have. And the information is actually made available for anybody to see through our snakebite information and data platform, who.int/snakebite. It's also important, and a big focus for us, I guess, has been the development of regional action plans. There's one already published in Southeast Asia. And earlier today, I sat in on a very good meeting based in Southeast Asia to celebrate International Snakebite Awareness Day with clinicians and policymakers. We are working towards a similar approach with Sub-Saharan Africa. And we're also hoping that our colleagues in PAHO, with some support, will be able to develop a similar strategy to customise the needs of snakebite patients and health professionals in different regions around the peculiar problems that they all face, so that they can better operationalise it. In terms of safe and effective treatment, and I know many think this is probably the most important aspect, but all of those other things that we've just been talking about are probably just as crucial. WHO is working on a number of different products, including target product profiles, which I'll talk about in just a second, an ongoing risk-benefit assessment of antivenoms in 3 different regions, Sub-Saharan Africa, the Middle East and North Africa, and the South Asian region. And we're also looking at the possibility of developing tools to improve the way in which we evaluate antivenoms, particularly in countries where running clinical trials is not very feasible or affordable or logistically possible, but where there are needs to be able to improve the sort of surveillance and the information available about the appropriateness of different products, their safety and their efficacy in those settings. And finally, we're also working on development of an antivenom stockpile project for Sub-Saharan Africa, which I'm also going to focus on in just a moment. So if we just do a quick deep dive into target product profiles, for those who don't know what they are, these are technical documents that provide guidance to researchers, to manufacturers, regulators, and other people associated with the development or the delivery or the control of different types of products. We already have published a target product profile for 4 different types of antivenom products that would be suitable for Sub-Saharan Africa. Again, it's available on our website, and you can get to it from that link that I mentioned earlier. These also cover things like small molecule inhibitors, and in the future we'll have another one on engineered antibody therapeutics to go with that. These are developed by a fairly robust technical team, and they cover all of the aspects of a product, whether it's just defining where the product will be used, its geographic usage, what the criteria are for suitability for use, what the exclusion criteria might be, defining how the product should be properly manufactured and the various parameters that it needs to meet, how those would be assessed, how it would be stored, packaged, and so on. And also, because these are intended to be public good packages, we also look at things like the cost, the training needs of health workers, and other ancillary types of issues that may be relevant to these particular products. Big part of the work that WHO is doing, though, and has for several years now, is a risk-benefit assessment of snake antivenoms. Very robust process. It involves an independent dossier review, extensive analysis of samples of products in a laboratory, looking at all aspects of how those products are manufactured and their in vitro and in vivo preclinical potency and even ability to neutralise specific types of toxins. And it's coupled with GMP inspections of the manufacturing sites to ensure that good manufacturing practices are being adhered to before it goes to back to our committee, and the committee will look at all of the evidence, and then they'll decide whether or not it's feasible to make a risk-benefit assessment in favour of actually having the product in the marketplace. Now, to give you an idea of what we're doing, in the Middle East and North Africa, we have 9 products that are under assessment. 6 are polyvalent, 3 are monovalent. In South Asia, currently 8 products are under assessment. 7 of them are for the classic big 4 species, the cobra, the crate, the Russell's viper, the saw-scaled viper. 1 is a polyvalent product that includes a 5th species, hypnali from South India and Sri Lanka. But in sub-Saharan Africa, we have had 15 applications. 2 of them we didn't consider because they were products that were intended for other regions of the world. 2 of our assessments have been terminated. One of those products has been represented to us after various issues were dealt with, and we are currently re-evaluating it. The second product remains terminated and is not recommended for use by WHO. We have actually published 3 product recommendations, and we have currently this year 9 other assessments in progress for which no decision has yet been made. When we do make decisions, they're published on WHO's website. Again, there's a link at the bottom of this slide, but you can get to it through the same link I mentioned at the beginning, who.int/snakebite, and then just follow the internal linkages. This provides information about the process, the results, where each product is at in the process, and eventually we'll also provide very detailed reports on GMP compliance and the laboratory results of our assessments. And of more interest, I guess, to principally sub-Saharan Africa at this point, but this is a program that we think may eventually extend to other regions of the world, and that's the development of a pilot project for the stockpiling of antivenoms. At the moment, we're looking at a pilot in 8 countries: Benin, Burkina Faso and Cameroon, Chad, Ghana, Niger, Nigeria and Togo. We hope to put a minimum of 2 WHO recommended products into these regions because, as you can see on the map in the very dark brown colour, this is an area dominated by carpet vipers, genus Equus, and then the bright pink are areas where Equus are absent. There's definitely a need for at least 2 products to cater for that need. This is the sort of program where we're looking at having a revolving stockpile, whereas the product is used, the countries would reimburse the stockpile to enable us to purchase more. It's very much data driven, and in implementation we are going to be working very closely with the governments of the countries, the African Regional Office, local experts and local civil society and other implementation partners, because we see this as a product that should actually be driven from the region more so than driven remotely. As part of the work for this, we've had to do quite a little bit of, I guess you'd call it homework, including mapping all of the distributions of the major species and groups of venomous snakes. And we've actually matched that with human population, agricultural and activity data, as well as ecological environmental data, to be able to predict areas where contact with these particular snakes is the most likely. So again, on each of these maps for the different groups, the darker the shading, the higher the likelihood of contact with these snakes by humans. We also use the same data to enable us to look at access to health facilities and the travel time that people face. We know that the sooner you get to hospital, the better. But in some cases, there are areas, and in the case of these countries, particularly in Burkina Faso, in northern parts of Togo and Benin, and in parts of Chad and Cameroon, where travel time of 5 hours, even 6 hours and above, is quite problematic. So this information gives us the ability to try and look at strategies for reducing that travel time for people in those particular areas. And we do the same with how we're going to deliver antivenoms from the capital cities to regional stores, and from regional stores to the actual health facilities themselves, in terms of working out travel time. And then, of course, we look at the distribution of the health facilities in the countries against the distributions of the various species of venomous snakes to identify exactly how big are the populations at risk. So in the example on the right-hand side for the country of Chad, you can see that there are currently about 52,800 people who would be more than 6 hours away from a health facility, but who are at high risk of contact with carpet vipers. And indeed, in the area where contact with carpet vipers is very high risk, there's nearly 7.85 million people that would be within 6 hours of a health facility who are at risk of exposure. So again, this information is essential to us to be able to plan this project, but it also provides a lot of valuable data that countries can use themselves to be able to better plan resource needs, see where they've got deficiencies in the current coverage, and address some of those problems themselves. And we also look to the future. On the left-hand side, just very briefly at the top, is the current habitat suitability for the black mamba in sub-Saharan Africa. All of the yellow dots are actual specimens that have been logged and their mapping work. The areas of yellow underneath that, the big areas of yellow, are where habitat suitability is the highest. The darker the colour gets, the less suitable the habitat. You can see that there's going to be some reductions in that during the next 25 to 30 years. By 2050, there will be some reductions, but by looking at the map on the right, where we give a sliding scale of reduced loss of range and increased loss of range, you can see that for South Africa, Swaziland, Lesotho, there's going to be a probable increase in the range of this snake as habitat changes. Likewise, along the coast of Somalia and on the eastern side of Nigeria, but in places like the border of Kenya and Somalia, parts of Ethiopia and Djibouti, and in the Democratic Republic of Congo, the range of this snake may actually reduce. And why do we need to know this? Because over time, health facilities are going to have to adapt to new risks, and it's very important that we get ahead of the curve in doing this. So we're actually doing this for all of the major venomous snake species right around the world, with the intention of making the data available through our website for people to use, both for their own research and to inform policy. And then lastly, I'll just touch on this question of how do we solve the problem of gathering clinical evidence for the use of anti-venom products, particularly in places where running formal clinical trials is very difficult, both logistically, financially, and ethically, especially in places where large numbers of people are being bitten and are dying or being left disabled by these sorts of animals. WHO several years ago developed a proposal for the monitored emergency use of unregistered and experimental interventions during the Ebola virus disease outbreak in West Africa in 2013-2014. And that model has been used in other Ebola outbreaks since to test experimental products. It's also been used extensively throughout the COVID pandemic for the same purpose, to facilitate easier and quicker access to promising experimental interventions that could save lives that would otherwise have been lost. And we think in many parts of the world at the moment where it's not feasible to run clinical trials, snake antivenoms present a similar situation. There are some prerequisites to using this sort of a framework. First of all, you need the agreement of governments to issue the emergency use authorisation through their regulatory agencies, but also to provide robust national ethics committee oversight. And that oversight would be to look at the very robust preclinical data, approve a treatment protocol that includes informed consent from patients, and establishes a data safety and monitoring board, a DSMB, that would look at compulsory case reporting on a progressive basis to be able to either say, yes, everything's working fine, we can continue, or perhaps no, it's not working quite as well as we want, so we need to either adjust the dose, or in the worst case scenario, stop using a particular product because it's just proving not to be either as effective or safe as it needs to be. And our goal here is that We want to improve access to existing, new and experimental treatments, make it easier to get new treatments into the market more quickly than would otherwise be possible. And at the same time, improve the oversight of products, particularly in countries where there's no current provision for clinical trials encased in regulatory requirements. In many countries at the moment, it's very easy to get a product for which there's no evidence of efficacy registered and a marketing authorisation given so that that product can be sold. And we'd like to sort of come in with something that's in between doing nothing and perhaps that gold standard that we wish we could aspire to, the randomised controlled trial, as a way of making sure that more people can get treated more quickly and sooner. All right, so I'll finish there. Our team is supported by the Neglected Tropical Diseases Department, Dr. Bernadette Abella, the Health Products Policy and Standards team, Dr. Yuyun Mariungasi, and in my department, the Regulation and Pre-Qualification Group by Carmen Rodriguez Hernandez. We have a number of external partners, key of which are the Wellcome Trust, Global Snakebite Initiative, and of course we work very closely with the consortium that organises International Snakebite Awareness Day. Okay, thank you very much.
David, thank you. Good morning, everybody. My apologies, my machine decided to freeze and remove me from the general conversation at the very moment of wanting to start this webinar. I'm glad I'm back with you. Without further ado, we have a number of presentations from the regional offices. I'm delighted with the regional offices are stepping up to the mark in their different ways as appropriate to their regions. This cannot be an initiative from WHO that is run only from HQ. I hope that is utterly obvious. So the first of these we have from Dorothy Achu from AFRO, and she's recorded a presentation for us which I hope, Kaushi, you're now able to share on her behalf. You can see a screen, Kaushi, but we're lacking volume.
I'm not sure why, but it's not getting the sounds. I'm trying.
I think it may be freezing.
Let me try to share it in a different way. My apologies. This is
Okay, while she's trying to make some progress, Kevin Arbuckle has posed an interesting question in the Q&A about travel times. These are estimates, Kevin. They are based on established literature, so they are quite good quality estimates rather than rough guesses. But they are only estimates, and they have to be averages. You raise a point and give an example.
Countries where access to healthcare is snakebite is sufficient. In our proactive approach to handling snake bites, since the introduction of snake bites into the NTDs,
my apologies for cutting you off.
No problem.
In the African region,
My apologies for cutting you off, Mike. You can finish the answer and then I can start playing.
Okay, so just to finish the comment, Kevin. So they are estimates. They are good quality estimates, but they're only averages. And your point about access to transport is a massive barrier. Yeah, we are doing what we can. What we would like to do is, when we go to and talk with ministries of health, have something credible and sensible to offer, which we can then modify and adapt with them, with their local knowledge. And that's the overall game plan and objective. Thank you. Koshi, back to you.
Thanks, Mike.
Especially from venomous snakes, the populations in the African region are heavily impacted by snake bites, especially from venomous snakes that lead to fatal outcomes. This situation is made worse because of lack of safe, effective, and affordable treatments that are accessible to those who need them. Furthermore, it is very difficult for us to estimate the number of cases, the disabilities, and the deaths that result from snake bites. But for now, the estimated numbers range from between 430,000 to 580,000 for hospital cases. However, these statistics are really underestimated because most of the cases occur in heavily impoverished agricultural and herding communities that live in low and middle income countries where access to healthcare is very insufficient. In our proactive approach to handling snake bites, since the introduction of snake bites into the NTDs in 2017, AFRO conducted 2 surveillance surveys in countries between 2018 and in 2020. And this showed that there were significant gaps in the surveillance and in the treatment of snake bites in venoming in countries. And this have also shown that at least we have a very great interest. 33 African countries have shown interest and commitment in mastering and tackling the snake bite envenoming as a problem of public health. So on the basis of this, we have made some progress. We noticed some progress in the introduction of snake bites envenoming into national health policies. There has been some progress in surveillance, so in reporting cases, but also in the availability of the anti-venom, which is the main treatment for snake bites. The concrete actions implemented by the African region can be summarized into burden estimation and the improvement of the use of data for decision-making, coordination and provision of guidance to member states, but also surveillance and improvement or strengthening of case management. So if we want to take, for example, burden estimation and the use of data, we have been working with countries, both AFRO and WHO headquarters, have been providing and disseminating standardized epidemiological forms to help countries to better track and report cases so that we can have a better understanding of the epidemiology and the importance of the problem. For example, these epidemiological forms for data collection have been piloted in Benin, Ghana, Eswatini, Nigeria, Tanzania, and Togo. And these have really helped to refine the quality of data available for actions in countries. And we are hoping that other countries will use these forms and be able to understand better the epidemiological situation. Secondly, in terms of coordination and the provision of guidance, In 2022, the African region held the very first stakeholders meeting, which brought together policymakers and experts to brainstorm on the solutions that could be used to address the problem within the region. And since then, we've been working, and it has set us the stage for the upcoming stakeholders meeting, during which a strategic framework will be developed to guide the prevention and control of snakebite envenoming in the region. Thirdly, we are looking at the improvement of case management. And to do this, we are conducting some studies to understand the mechanisms and systems that exist for improving the production, the procurement and the supply of antivenom and other treatments that are related to address snakebite envenoming. We are hoping that with the better knowledge of this, we are going to support countries to put in place more robust systems to manage the procurement and supply chain of antivenom, so that these treatments are available to those who need them. However, the key challenges have been insufficient opportunities, investment opportunities to strengthen the capacity of communities that are affected, so that they can prevent, because it's a very preventable condition. They can prevent and treat. We also need resources to be able to procure antivenom, support countries to procure antivenom for the affected communities, and also to invest in research and innovation. So going forward, as a regional office, AFRO is committed together with her partners to continue supporting countries in collecting quality data and in using this data to respond to the burden of snake bites in the region. We are also committed in disseminating updated guidelines for the case management of snakebite envenoming, and that would mean procuring the use of antivenom but other treatments. We are also committed in making sure that the snakebite activities are integrated into the NTD's resource management plans that countries are developing at the moment.
Thank you. I hope you all enjoyed and found as instructive that presentation from Dr. Achu as I did. Without further ado, I'd like to move to the Americas, and Dr. Felipe Rocha, I believe you're on the line and you have a presentation to give us, if you would, please.
Yes, can you hear me?
Yes, I can.
Yes.
Excellent. Thank you.
Perfect. Let me share the screen here. This one. Yes, share.
Yes, we
I
can
believe. Yes.
the screen. Excellent.
It's already on presentation mode.
Yes, it is.
Perfect. So, first of all, I'd like to start saying thank you all especially for the Veterinary Public Health Environment and Vector Control Unit for the invitation, for promoting this day and for organizing this event. Also, I'd like to thank you all that are following this webinar. So my name is Felipe Rocha. I am a technical officer for zoonoses and veterinary public health here in the Pan American Center for Foot and Mouth Disease and Veterinary Public Health of PAHO. So the venomous animal accident poses significant public health challenge here in the Americas, particularly affecting vulnerable populations. These incidents are closely connected to social, economic, and environmental determinants, and their true impact remains underestimated in the region. Specifically, ophidian accidents affect approximately around 60,000 individuals annually in the Americas, especially in Latin America, with a 0.6% rate of fatality rate and significant sequela and disabilities. Brazil alone represents almost 50% of the cases. In 2020, there were almost 600,000 cases of venomous animal envenomation in the region. And I would like to highlight that 76% were attributed to scorpions, while snakes were responsible for just 8% of the cases, although snake bites were responsible for 32% of the deaths in the region. And the scorpion is concentrated disproportionately in urban areas compared to snake bite incidents, and affect especially children and young people. So snake bites are more frequent in rural areas of the region compared to other venomous accidents, far from the health centers compared to the scorpions, for example. The antivenom distribution faces obstacles due to inadequate records, bureaucratic procurement procedures, and limited budgets. Furthermore, antivenoms are concentrated in hospitals and big health facilities and do not reach the rural health centers. Cold chain issues and deficient healthcare services in high incidence envenomation areas also pose significant challenges. So we try to take a look at holistic and systematic approaches. And these views are required, employing the concepts of an eco-salute or eco-health and One Health from a transdisciplinary perspective, with community, with social involvement, and action on the solutions, on find the solutions, and how to go ahead to address the issue. The antivenom productions involves both public laboratories and some private centers here in the region of the Americas. These antivenoms are based on two types of active substance, equine IgG and equine Fab. In 2018, we have established the Public Laboratories Network for Antivenom Production, the HELAPA, and it was established comprising 13 public laboratories of the region of nine different countries that are currently producing antivenoms. PAHO has also been providing technical cooperation to strengthen national programs and promote professional training and enhance the availability and accessibility of effective and safe antivenoms. For this particular day, we have developed, with the support of regional experts, two pieces of communications. One specific for how to prevent snake bites, another one specific for what to do in case of an event of accident involving a snake bite. These materials are available in our Facebook and XP profile pages, and also we have distributed this for the countries to be printed and to be used in the way the countries feel better. So with that said, I would like to thank you all for the opportunity. I would like to thank you for the organization, and I'll be here for the discussion panel. Thank you all.
Felipe, in my turn, thank you. Lovely presentation. And contrasting those three presentations, I hope you all came out with the same sort of messages that I did. There is so much that unites us. There are commonalities of problems. The epidemiology, or often lack of epidemiology, the difficulties with the purchase, distribution of venoms and making them antivenoms and making them available. And yet also we see a lovely example of why regions need to do some things differently from each other. In the Americas, most of your antivenoms are produced by public laboratories, and you have them in a network. Much of the rest of the world does not have that system. It's mainly commercial. Not all, but mainly commercial suppliers. And there's not a right or a wrong, it's simply a noted difference. But because there's a difference, we have to respect that difference and work accordingly in the regions. So, as Felipe has already said, we'll now move into 20 minutes of brief question and answer session. And I'm absolutely delighted that we have joining us for this Dr. Wolton Monteiro from the Amazon region of Brazil, Dr. Abdul Habib from Kano in Nigeria, Felipe is still with us, and David's still with us as well. Though if you don't mind, David, given that we've heard from you already, I'm going to ask Wolton and Abdul to start fielding questions. Now, please, everyone, if you have questions, please put them in the chat, and then we can prioritize your questions. If you do not have questions, don't worry, I have questions anyway that I can use to start off the process. So I wonder if I might start. Wolton, would you mind if I ask you the question, what's the current situation in your country, well, in your region of Brazil?
Hi, can you hear me?
We can, thank you. And we can.
Okay, thank you for the invitation for the team. I'm very happy to be with you here today. Then the history of the snakebite control in Brazil started with more proeminence in the decade of the 80s of the last century, when a plan to achieve self-sufficiency in manufacturing biologicals for public health has been structured in the country in the context of a reform in the health system. Then the industrial plants of the National Public Laboratories, as said Tiago in his presentation, have been modernized, and a program for reducing morbidity and mortality of venomous snake bites has been created as part of the National Epidemiological Surveillance System. The epidemiological data is reasonable in the country. The snake bites and scorpion stings and spider bites are of mandatory reports in the country, and was essential for to help to quantify the production of the vials for antivenoms for these problems in the country. And the acquisition of all the antivenom production is made by the Brazilian Ministry of Health, which is the exclusive purchaser in the country. Distribution is decentralized to reach hospitals in almost 3,000 municipalities across the country, and to provide free of charge antivenom treatment for the patients. However, despite all the advances in the health system, antivenom availability and accessibility is not uniform in regards to the most vulnerable parts of the populations, which inhabit most remote areas in the country, especially in the Brazilian Amazon. In these places, we need a better logistics and transportation of the liquid form antivenoms to address the problem in these health units in these remote areas, with a realistic and comprehensive health program for indigenous groups, especially in riverine populations. And we need this in order to reduce the high morbidity and high mortality rates associated with snakebite envenoming in these most vulnerable groups. Then this is briefly the summary of the snakebite epidemiology and control strategies in the country. We know that in Amazon region, especially indigenous areas, we have an incidence 5 higher more than in comparison with the non-Amazonian regions. Mortality is almost 5 times higher in these populations, and the presence of sequela disabilities from snake bites are very high in these populations in the Amazonia, Brazilian Amazon region.
Okay, thank you, Volta. And although the geographies around the world are very different, this common message that it's the remote populations, rural populations that are most vulnerable to getting bitten and are then most difficult to access and get treatments to, or get into treatments. We hear you, we hear you. I'm delighted we have a couple of questions from our attendees. I wonder if John Wakisa, if you could give us your question, please. John, you raised your hand. We don't hear you. The other hand raised was Dr. Niego, if I hope I pronounced that correctly. Could we hear your question, please? You're both muted.
Hello.
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 Is that Dr. Niego?
Yes, do you hear me?
Yes, we can hear.
I'm Dr. Niego.
Please give us your question.
Okay, thank you. First of all, I would like to congratulate for the nice presentation. I'm interested with someone who have presented before, Dr. Achu Doroth. He have shown the distribution of venomous snake with respect to suitability. I captured that slide where he indicated the suitability for Dendroaspis polylepis snake. Now, I wanted to know in detail. Currently, we are in the global climatic change worldwide. Now, I'm interested to know if the global climatic change influences the suitability for survival of venomous snake, or it discourages the suitability for survival and the reproduction or replication of those venomous snake, especially like those species of Dendroaspis polylepis, as he have displayed in his presentation. Thank you.
Thank you. Very good question. And you're clearly picking up on a really exciting piece of data. David, you know the data better than I do. Would you like to respond?
Yes. So I guess the short answer is that climate change is already having an impact on the distribution of venomous snakes. We've seen data coming from southern United States showing that the range of some species is starting to extend further north than it did previously because the winters there are much milder. Similarly, in Argentina, there's some evidence that some species of snakes that used to be confined to lowland areas are now being found much further up the slopes of mountain ranges. And over time, what will happen is the climate in different regions of, for example, sub-Saharan Africa changes, is that there will be some parts of the region where the habitat will be less suitable for some animals, but more suitable for others, and vice versa. And this means that the distribution that we see now may shift into either new habitats within a different area of the country to where that animal currently occurs, or within the area that the animal is found within the country, areas of microhabitat that it previously did not occupy. And again, such as the example of a snake that would predominantly be found in lowlands, now deciding that it's going to live up the side of a mountain where it's a little bit cooler. Those sorts of things are going to occur. And certainly for black mambas, we predict that the range in southern Africa will extend further to the south as the climate there warms and the winters become milder. But in some of the areas in the northern part of its range, up near the bottom of the Sahara Desert, where the temperature will just be completely intolerable, and where some of the desert areas are going to just be baking hot, that snake will no longer be able to survive there. But of course, these are predictions based on current climate change models. And of course, what we need to do is to continue to update these as time goes by, rather than just taking a snapshot of what we have now. So it's very much going to have to be a work in progress, but it could potentially mean that there will be people who are not at risk of bites from such as a black mamba at the moment, that in 10, 20 years' time may actually find that those snakes do now occur where they live and do present a new and otherwise, threat that they've never had to deal with in the past.
Thank you, David. I hope that's given you a flavour of some of the thinking, Dr. Nyogo. John Makisa, you had your hand up as well. Oh, you've gone muted. Can you unmute? No, you're still on mute, I'm afraid. While we're waiting for Dr. Wakisa, I wonder, Abdul, if we might turn to you. You and I have known each other for a couple of years, but I know that you've been working in this field for a long, long time. I wonder, people working together, what is the best way that you have found for getting all these different disparate stakeholders to work together for the common cause? Because I know you've managed to make it happen in a way that few of us have. Lots have tried. What's your magic trick, Abdul?
Well, thank you. Thank you very much, Mike, for that question. Well, generally, as you know, it's very difficult to get people from diverse backgrounds to come together and work as a team. But I guess the persistence and the perseverance, and also the showing that one part about the problem, also the share the people come to table with somehow help. One is trying to better the conditions of impoverished snakebite victims in rural areas in a sincere way and in a consistent way over years, and urging people to support him. I think that helps really. It's not so much to do with the material gains. It's just the persistence, and for people also to see tangible results. If people can see tangible results, that mortality is less from snakebite, a recognition of a hitherto unrecognized entity. I mean, if you go back 2 decades ago, no one speaks of snakebite throughout the whole world, if you say, and especially in our countries where our leaders even stigmatized it, and people working in the field were stigmatized. But if one perseveres in time with the recognition, things like International Snakebite Awareness Day are even somehow implemented yearly now. And policymakers, ministers for health in these countries are called upon every year for the past 3-4 years. The Honorable Minister for Health in Nigeria comes on the media and promotes the problem of snakebite, the challenges, and also the solutions, and what the government is doing to intervene. In time, other subnational entities somehow join the force. And then when you come to the professionals, at times you realize, as colleagues have pointed out, senior colleagues have suggested, that really the answer has to be through transdisciplinary approach rather than through healthcare only or through healthcare and social scientists. Every professional, those in veterinary sciences, in One Health, have to play their role. Those from the ecology and geography and spatial epidemiology also have to play. If they all come together, you start having a picture, you start having a characterization of the problem and potential solutions that some of us in the health sector may be blinded to. Others from outside the field, agriculture, for instance, may see and say, we've been doing this about dry land agriculture, and this is the way to characterize the spatio-temporal aspects of it. But the bottom line, as was pointed out earlier, I think investment, funding, good estimates, teamwork are all needed around the table if we are to make some significant headway in providing solutions to snakebite.
Thanks, Abdul.
Yeah.
John Wakisa, I need to give you another chance. I hope you're able to unmute. You've been very patient, and we'd like you to be able to contribute. But maybe your connection isn't so strong. Dr. Nyogo, you've raised your hand again.
Yes.
Please.
Hello.
Yes, we can hear you.
Okay, now thank you for the second chance. I wanted to know, there is the first presenter and I think presentation from PAHO. I'm interested and well motivated with the good and the great job done by our colleagues from South America and North America. I think if that presentation from PAHO with respect to production of antivenoms. As we know that snakebite envenomation have been reported as the disease of poor, affecting the most poorest people in different areas worldwide. And there is global strategy toward the awareness and other things as it have been presented in, I think in the first presentation. Now I wanted to know if there are any global strategy toward making sure that antivenoms are readily available and at least at the achievable, at the affordable cost, so that even those poor whom we are mentioning are able to afford the price for antivenoms, since snakebite envenomation have become a public health event affecting many populations, especially in the rural areas. Thank you.
No, thank you. That's a really important question, but it's a very, very big question as well. If you don't mind, Felipe, would you like to answer the first part of the question? How did you manage to pull together all these public sector labs to work conjointly? And does it work well enough that you can actually generate antivenoms and get them to the right people at a price that is, if not affordable, is not catastrophic? What's your experience we might learn from?
Yes, well, first of all, I think the point is that governments have understand that because of the difficulties and the particularities of each species for each kind of antivenom, it's understood that to have the antivenom specifically for the species in your territory is a strategic question for the government, for the local authorities. So the problem is that we can have a product from one country, maybe probably won't be used in other country because of the difference between the species of different species. So the governments have to see this in a strategic question and a strategic point. And there are this public laboratory. Because of that, most of the Latin American countries have these laboratories, public laboratories, to support the national programs on helping and providing treatment for people. These laboratories have a lot of problems also. They have problems with regulations, questions. They have problems with investments for maintaining their production. And the idea of the creation of this network is that the laboratories can support technically each other and a direct technical cooperation between the manufacturing laboratories, the producers, to improve their technical capacity in the provision of these antivenoms. Besides that, there is other problem that is not related to the laboratories and the production. That is the distribution of this, and the distribution of the antivenom is related to the national programs. So we have to focusing and working these two parts that may be seen as separate, but that they are part of one thing. to support the improvement of the quality and the number of antivenom produced, and also to support national programs on understanding their real impacts on the snakebite and how to properly distribute and provide treatment for people.
Thanks, Felipe. So there you have it, Nyogo, Dr. Nyogo. There is politics involved. Is getting the minister and relevant, very senior people in governments to buy into this. It's about the technical side of things, and it's about procurement and distribution. As with so much in snake bites, there is no magic bullet. It is multiple aspects. Getting one right won't work on its own, but if you get 5 or 6 things nearly right, then we will all make progress. I'm conscious of the time. Dr. Wakisa, are you still available there? No. No. In which case, David Williams, you've just put your hand up.
Yeah, Mike, I just want to circle back to this issue because I think it's a really important one. And beyond the manufacturing side and beyond the logistics issues of distribution, there's another really important thing that we have to consider. And I'll preface this by saying I'm not a politician. I have no political aspirations, so I'll be rather blunt. In 2018, the World Health Assembly adopted a resolution on snakebite envenoming, in which countries all agreed that not only did they call upon WHO to help work on this problem, but the countries also agreed that they themselves would undertake greater efforts to improve the situation, particularly for the most poor and vulnerable people in their communities. And to be really blunt, I would say that in the time that's passed since then, the majority of them have done nothing. It's amounted to nothing more than words. And until such time as we start to see more and more countries doing more than just give us rhetoric and nice platitudes and promises, things are not going to change. There's no excuse for the poorest people in communities anywhere in the world to have to spend more than, the total amount of money they're going to earn in a whole year to try and save the life of a loved one. We need to find other ways in which we can make these sorts of medicines, which they're emergency drugs. People don't need them next week or in a fortnight. If you get bitten by a venomous snake, you need that product ASAP, or you are either going to lose your life or lose a limb or lose your livelihood or lose all of the above. And so I would encourage the people who are listening to the webinar today to go away and think about how they can continue to advocate with their governments to do more. I really think we need to go back to holding their feet to the fire. I know our good friend Tim Reed is in the audience. Tim was pivotal to the work that was done to get snakebite, back onto the agenda. And I think we all need to keep doing that. We need to go back to a World Health Assembly and demand that they do more than just talk about it. There are lots of ways that this problem can be solved, but first and foremost, it really does require that governments actually make a definite, demonstrable and sustained commitment.
Okay, thanks, David. I think that's actually a really interesting place to leave the conversation. It's a challenge to all of us. Those of you who have, if any of you have direct access to the ministers in your governments, please know that we are all behind you. Please go and approach them and try and make things happen. Those of us who don't, which I suspect is the majority, we find what routes we can to make progress. But the challenge is there. The problems are still there. We need to step up to the mark. I'm a glass half full sort of person. We have terrible problems that need to improve, but we have a situation which is better than it was 10 years ago. Yes, things have been too slow. Things are very frustrating, but we do make progress. We not make enough progress? No, but we are making progress. We need to make more progress, and we need to do it faster. And with that thought, I would like to thank all of you who've contributed to this conversation, particularly our friends who've made particular presentations and who joined the panel, Wultan and Abdul in particular, Felipe and Dr. Achu, and the questions we had. And I'm sorry, Dr. Wiki, so we didn't actually got to your question. And thank you and goodbye.